Talking about the condition which is known as stroke, we must know that it is one of the leading cause of death in the US, as well as almost 6.2 million deaths were recorded in 2015, according to the researchers, and they were caused due to this ischemic stroke variety. Then obviously it is one of the leading causes of disability as well. So it's kind of very important to get to the background knowledge and have the core knowledge to the development of this condition. What is the pathogenesis of this condition? What are the underlying mechanisms behind the development of stroke, as well as what are the clinical types of stroke that we're going to discuss today. In this lecture, we are going to summarize the type which is known as ischemic stroke, but we have another variant which is known as the hemorrhagic stroke. Stroke, in other words, it's basically the cerebral vascular accident that basically means or terms the death of the brain tissue that can occur due to the ischemia, and this ischemia is basically resulting due to the lodgement of the ambulus or the lodgement of the thrombus that travel through the vasculature and end up in the vasculature of the brain. As we all know through the background knowledge of the anatomy, that the blood supply of the brain is basically supplied through the circle of Willis. Now, this circle of Willis is something very important. Basically, it leads to the knowledge that there are a lot of collaterals when we talk about the brain. So it's kind of very difficult if we say that there is a tissue damage occurring in the brain due to the vasculature, due to the ischemic conditions that arises in the brain vasculature. That means that there is the lodgement of the ambuli. Now, where does these ambuli come from? Where does these ambuli travel from? Usually it is the internal carotids of the neck of the patient. So you as a medical officer are going to come across a lot of patients who are going to present to you in the outpatient departments with a history of fall, with the history of slurred speech, with the history of disturbed gait, unconsciousness, history of seizures, and all of these are basically going to give you a typical picture of an ischemic stroke kind of variety. When you're going to take the history from these patients, you're going to focus on the risk factors that can lead to the development of this condition, which is known as ischemic stroke. Now, there are a lot of medical conditions that basically predispose an individual towards the development of ischemic stroke variety. The patient can give you a history of if he or she is a diagnosed case of hypertension, diabetes mellitus. It can be a history of active or passive smoking, diets, and sometimes it is usually the history of high cholesterol levels in the blood that basically predispose the patient towards the development of ambulus or thrombus formation in the neck carotids. And when these dislodge into the vasculature of the brain, they're going to lead towards the ischemia of the brain tissue, or in other words, it is going to lead to the death of the brain tissue. Now, we have different conditions. For instance, we have the ischemic variety of the stroke, we have the hemorrhagic variety of the stroke, in which there is a completely different scenario. That is basically the hemorrhage is going to damage the brain tissue, and that is basically regarded as the hemorrhagic kind of stroke. On the other hand, we have TIAs, that is the transient ischemic attacks. Now, when we use this word, that is basically the transient ischemic attacks, we mean that there are no constant changes on the radiographic studies, and as well as the patient's neurological signs and symptoms also improve with the passage of time. So these are the different clinical scenarios which you usually come across when you'll be dealing with these cerebrovascular accidents varieties. So this is a diagrammatic representation of the internal carotids. As you can appreciate over here, this is the internal carotid artery. We have a common carotid artery leading to an internal and an external carotid artery. And this internal carotid artery is in turn going to give a branch which is known as the middle cerebral artery. Now, if there is a thrombus that is located inside this internal carotid artery of a patient, that can be dislodged at any time. So it's a very risky factor that can be present in an individual. Usually the patients would be presenting to you in the outpatient departments with the history of a recent MI, that is the myocardial infarction. And when you're going to take the history in detail from the patient, they're going to reveal the facts that they're also suffering from the other risk factors, for instance, the diabetes mellitus, the hypertension, high cholesterol levels in the blood. And all of these are going to increase the risk factors towards the development of thrombus formation in the major arteries, in the major vasculature, such as the internal carotids of the neck. There are different studies. For instance, we have the Doppler studies that can be carried out for the neck carotids, and they reveal the fact whether they're occluded or not, or whether there is a normal flow in the internal carotids of an individual. So if there is a blockage to any extent, that is basically revealed when you carry out these Doppler ultrasounds for the neck carotids, and that is how you're going to basically make sure that this person is at a high risk of developing cerebrovascular accident, or any further incidents of ischemic strokes can be evaluated in a particular patient. So over here, it's basically giving you a representation that the blood clot, it can break off as an embolus from the plaque buildup in the carotid arteries of the neck. And it can basically, due to the direction of the flow, due to the normal direction of the flow, it is going to go up into the brain vasculature. That is there is an upward direction of the flow in all of these vessels. These cerebral arteries within the brain are present, and the grayish area is basically giving you an eluded way in which you can basically depict what it will be the location of the brain tissue death in this particular individual. So the embolus in the cerebral artery blocks the blood flow to the part of the brain, because that is basically a minute vasculature. And again, it is basically depending upon the amount of blood flow that it is going to restrict to a particular area, that is going to determine the kind of death, whether it is a reversible kind of changes that are going to be observed in this individual, or whether it is going to be the irreversible kind of brain tissue death in these individuals. So this is a magnified view of the area of the cerebrovascular accident, in which we're emphasizing on the fact that the embolus is basically blocking the blood flow when it goes to the minute or the mini vasculature of the brain. So this is how roughly, on a layman terminology, we can define how a cerebrovascular accident can take place in an individual. As we've already discussed the fact that we have two major variants for the stroke. One of it is the ischemic variant, and on the other hand, we have the hemorrhagic variant of the stroke. Just to have a better view and a better understanding of these two variants, this is a diagrammatic representation in which, whenever there is the lodgement of the embolus or the lodgement of the thrombus, and it basically dislodges from a major artery and gets to a mini vasculature of the brain, it blocks the blood supply to a particular area of the brain and results in the ischemia, or results in the brain tissue death in a particular area. That is going to be known as the ischemic variety of the stroke. On the other hand, we have this hemorrhagic variant of the stroke as well. It can be due to the hypertensive accidents that can occur, leading to the rupture of a blood vessel, and that rupture of the blood vessel is going to in turn result in the hemorrhage in a particular area. The collection of blood in this particular area of the brain is going to cause the damage to the brain cells, and this variant is known as the hemorrhagic variant of the stroke. Usually when you'd come across these patients, clinically it's very difficult to differentiate between an ischemic variety or a hemorrhagic variety. Once you will have to diagnose the patient whether this particular patient is suffering from stroke or not. We have a list of differential diagnoses from which we have to choose from. It can be a patient of a simple migraine or even a lot of seizures, and patients with epilepsies also resembles these cerebrovascular accidents. Then even a lot of metabolic disorders also present to you with the same signs and symptoms. There are basically the neurological signs and symptoms. So it's sometimes quite a confusing picture. To get to a definitive diagnosis, it's very important to know the differences between all of these conditions. When we say that it's basically a metabolic variety of cerebrovascular accidents, it's a fluctuating mental state that is noted down in these individuals. They're usually disoriented, not coordinated with the time and space, and that is basically going to lead to a clue that this particular patient is suffering from a metabolic variety of the accident. And then we have another variety which is known as an acaphalic migraine. Now, it's very important that you know this terminology. What do we mean by an acaphalic migraine? Usually, the migraine is also linked up with the pain. And if it is a pain-free migraine, that is usually termed as the acaphalic migraine. The signs and symptoms are sometimes quite similar to an ischemic stroke variety. The patient will also suffer from weakness in an affected part, in an affected limb, on an affected side, and sometimes he may also suffer with the slurred speech and dizziness, and all of these features are even a part and parcel of the acaphalic variety of migraine. So it's very important that you distinguish between all of these conditions and get to know and get to establish that whether this patient is really suffering from an ischemic variety of stroke or not. Then only you would start off with the labs, and the baselines are also conducted in this particular kind of variety, and then you move on to the radiological imaging techniques such as CT scans and MRIs, and they are going to reveal whether this particular patient is suffering from any cerebrovascular accident, either of the ischemic type or either it is of the hemorrhagic kind. So it's only the radiological techniques that are going to distinguish between these two varieties of the strokes. Again, there is another variety which is known as the TIAs. Now in TIAs, what happens is the patient's neurological signs and symptoms are going to improve over a period of 24 hours, and there are going to be no signs when you carry out the radiological imaging in these patients of TIAs. So although there was an accident, although the patient suffered from ischemia, or the patient suffered from an attack of hemorrhage, but still there are no signs to be seen on radiological imaging. Again, there is a criteria which you have to remember. If there is no blood flow, then obviously it takes almost 4 to 10 minutes for the brain cell death to occur. And if it is the blood flow is almost lessened up to 16 to 18 milliliters per 100 grams of the brain tissue, then it is going to take an hour to cause the apoptosis or the necrotic activities of the brain tissue to take place. Again, if the blood flow levels are less than 20 ml per 100 grams, then it is going to take several hours to develop the signs and symptoms and the clinical appearance of the ischemic stroke. So you'd come across all of these patients. Sometimes, if it's just a milder attack of the ischemia in a particular patient, the patient would not even notice any kind of an attack by himself or herself. This condition is sometimes also known as agnosia, which is basically in which the patient is uncoordinated. He or she doesn't feel the slurring in his or her own speech, or even he or she is not even able to appreciate the weakness in any side of the body or in any particular limb. So it's again, usually the parents and the relatives are going to note down all of these factors, and they usually bring the patient to the emergency departments, and they will give you a correct history regarding the complete illness of this particular individual. So once you have these patients at your hand, it's very important to take the history from the patient as well as take the corroborative history from the person who brought the individual to the hospital, as well as perform the neurological examination just to get to know the amount of weakness, or whether it is the hemiplegia, quadriplegia, diplegia, or if it's just the involvement of a single limb, it is known as monoplegia. So all of these plegic disorders or the paralysis are resulting due to this condition, which is known as stroke. Obviously, this condition can arise in the cortical areas of the brain, as well as it can involve the areas of coordination, of balance, areas involved with the planning of the voluntary movements, that is the cerebellum. So it's depending upon the area or the area of brain cell death that is occurring, and that is going to give you the final picture in a particular individual. For instance, if it's the cerebellum, or if it's the flocculonodular lobes, or there are certain lobes in the brain that are damaged, that is going to correspond to the particular clinical picture in this individual. So it's again very important just to get to a particular diagnosis, and that is going to happen only once you have those CT scans and MRIs on your hand, and you're looking at them and you're just having a complete view which lobe or which particular area of the brain is involved in this ischemic stroke. So the pathogenesis of the ischemic stroke, as we go about it, if it's a small artery occlusion, and then even it can be a large artery atherosclerotic changes that can occur in a particular individual. We have the cardio-aortic embolism. Then we have the other varieties for these ischemic stroke kind of varieties. It can be the vasculature of the kidneys that are involved, the liver, all of these different vasculatures are sometimes involved. And then we have a final variant, which is basically the idiopathic variety for the development of the ischemic stroke in the individuals. Now, whenever we refer to this acute ischemic kind of variety, we must know that it can be less than 20 millimeters of the basal or the brainstem penetrating arteries. As I've already discussed with you, that we have this collateral circulation in the brain, which is known as the circle of Willis, and then we have the internal carotid arteries, we have the middle cerebral arteries that are contributing towards the circle of Willis. And it's again very important to maintain this collateral circulation for a normal blood flow towards the different certain areas of the brain. So the blood supply to the brainstem has to be established, even to the cerebellar areas, to the cerebellar peduncles, to the two cerebral hemispheres, and all of these areas are the major areas that are being supplied by this small arteries of the brain. Then we can have the large artery atherosclerosis, atherosclerotic plaques with less diameter of intra and extracranial vessels, more than or equal to 50% or 50% stenosis. So whenever you carry out these Dopplers on the carotids of the neck, they're going to give you the exact percentage of the arteries that are occluded by that thromboembolic plaque that is present over there. So if it's a 50%, that is a danger sign. That means that it can be dislodged towards the microvasculature of the brain. So we can have all of these conditions whenever there is a raise in the cholesterol levels of the blood of an individual. It can even include the small arteries. It can even involve the large arteries. And even in conditions, for example, diabetes, they also predispose the patient towards the development of these thromboembolic plaque conditions. Now, the clot can form in the heart as well, and it can then further on travel to the brain. Whatever the cause is, it can be even an unknown cause towards from where an unknown destination from where the plaque is traveling towards the brain. Whatever the condition is, if the plaque has traveled towards the brain and it has reached a certain area, it has blocked a certain vasculature, it is going to result in a decrease in the cerebral blood flow. That is a major event in the development of the ischemic stroke of a patient. An increase in the glucose metabolism in the penumbra. So what is this penumbral region? What do we mean by this penumbral region? It means that there isn't a complete blockage of the blood flow. There is a slight blood supply that is maintained towards a particular area, and as a reflex activity, what is going to happen is it is going to increase the glucose metabolism inside the body of the individual. The peri-infarct depression. So what will happen due to this increased glucose metabolism is that the patient can experience these episodes of depression like depolarization, bipolar disorder, mood disorders. Usually the patient would come up to you with all of these features of depression as well as mood disorders. It is going to be in the area of the peri-infarct. This is going to be an event that is going to be marked over here. Then obviously we have the active biochemical pathways that are going to get active in this particular area. An increase in the volume of the infarct is going to take place. Now, a decrease in the cerebral blood flow is going to mark the decrease in the oxygen as well as the glucose in the infarct location. So, a decreased blood supply, there is going to be an anaerobic respiration in the cells of the brain. This is going to mark the development of the other factors or the other processes or the cascade of events that is going to take place in the ischemic stroke and lead towards the brain cell death in this particular individual. The anaerobic metabolism was the key event over here, and that is the mainstay. It is going to give rise to these two incidents that are the main cascadal events over here. What the patient is going to suffer from, he's going to have a decreased ATP as well as an increased lactate due to the presence of this increased anaerobic metabolism that is going to take place due to decrease in the oxygen supply to a particular area. A decrease in the ATP is going to cause a dysfunction of the sodium-potassium ATPase pump on the neuronal cells. And this dysfunctionality of this ATPase pump is going to give way to the water influx along with the sodium, and an increase in the sodium, calcium, as well as there is going to be an outflux of potassium. So these are again the key events leading to it can be a condition which is known as cerebral edema, which is a condition arising after an infarct. So infarct is sometimes led by the condition of cerebral edema in the individual. As well as this edematous condition is when we have a well-versed edematous condition in the brain. It is going to compress the vessels as well as the tissues, and it is going to finally result in the breakdown of the blood-brain barrier, allowing the influx of proteins as well as all of the other constituents that are blocked by the blood-brain barrier in the normal situations. As a result, the key event over here is the secondary inflammation that is going to take place. An increase in the sodium and the calcium influx and a potassium outflux that was maintained over here will be marked by the activity of depolarization in these cells. Now, what is going to happen is the neurons are going to release the glucose, and the astrocytes are also going to release the glucose. Excitotoxicity is going to occur due to this release, as well as there is going to be an activated metabolism of glucose. Increased calcium influx is going to result in the activation of the catabolic proteases, lipases, as well as nucleases. Then obviously it is going to take place is the oxidative and the nitrosative injuries. Basically, what we can mark over here is that we have two kinds of injuries that are taking place over here. First of all, we have the necrotic activity that is taking place due to the secondary inflammation that was built up in the cells. And on the other hand, we have the apoptotic activity. That is the cell death was programmed, which was programmed for the cells. So these two activities are going to result in the cell death of the brain tissues in this particular individual. And finally, it is going to result in the necrosis. Then the astrocyte cell deaths are going to take place, the microglia cell debris. Astrocytes, microglia, they are the key features for the blood-brain barrier. And if the deaths of these cells are going to take place, it is going to result in the breakdown of the blood-brain barrier. The release of the TNF-alpha, IFN gamma, and IL-1B, all of these interleukins and tumor necrosis factors that are present, they are basically the signs of chronic inflammation. And all of these, we have basically a complete picture of necrosis, a complete picture of apoptosis, inflammatory reactions, either primary or secondary. They're going to lead to the building up of the cell death in the brain tissue. Final result would be a clinical picture in the individual. The cell death or the brain death that is going to take place in a particular area. If it's the Wernicke's area, if it's the Brodmann's area, it is going to result in a slurred speech in the individual. Then the patient might suffer from weakness in particular limbs. Visual field losses are also suffered from by the individual. And then we have the histories of the autonomic dysfunctions, for instance, the urinary incontinence, and all of these would be the key features when we are noting down the history from the individual. So these are the cascade of events that take place and lead to the development of the brain tissue death or brain cell death in an individual who is suffering from an ischemic variety of stroke. These cascade of events can be summarized over here in general terminologies when you're not discussing the biochemical events that are taking place. The arterial occlusion is going to give rise to the glutamate release, and it is going to in turn result in the glutamate receptors that are activated over here, and they're going to give rise to the calcium and sodium influx that was responsible for the edematous conditions of the brain cell. Then again, there are multiple factors for the development of this calcium and sodium influx. It can be even the ischemia itself that leads to the energy failure, and again resulting in the calcium and sodium influx in these individuals. The thrombolysis is going to result, or thrombectomy is going to result in the reperfusion or even in the damaged cells that are being apoptotic or that are being necrotic in the individual. There's going to be the reperfusion of all those areas. Now what happens over here is the calcium and sodium influx is going to release the proteolytic activity of the enzymes that is going to result in the membrane and the cytoskeletal breakdown, and finally the cell death of the brain tissue occurs. Over here, it can be the apoptotic activity in itself that can also give rise to the cell death in these individuals. Again, even after treatment, by giving the thrombolytic activity, by performing the reperfusion, even this reperfusion is going to give rise to the inflammatory responses itself. the leukocytic addition, and it is going to give rise to the arachidonic acid production, which can give rise to the phospholipases to get activated, and they even can give rise to the membrane and cytoskeletal breakdown as well. Then the formation of the free radicals are again going to be causing damage to the brain cells as well over here. All of these cascade of events, either necrotic or apoptotic, are going to result in the cell death in the brain tissue. Now, how do we approach a patient who is suffering from stroke or who is either diagnosed to be suffering from the TIAs, that is the transient ischemic attacks, or the management guidelines that are related to these patients are, you'd basically start off as any other emergency, that is maintaining the airway, breathing, and circulation, and then maintaining the glucose levels is quite critical over here. It can be the hypoglycemia that has to be treated, or either the hyperglycemia in patients who are suffering from diabetes mellitus. You have to control the hyperglycemic conditions as well. Then you have to obtain the brain imaging. Either you carry out the CT scans and MRIs just to distinguish whether this patient is suffering from a hemorrhagic variety or an ischemic variety of the stroke over here. Ischemic strokes, or the TIAs, are the most common varieties of strokes. That is, almost 85% of strokes are occurring due to the ischemic variety. Thrombolysis and thrombectomy. Then we perform basically this thrombolysis by giving off the tissue plasminogen activator timely to the patient. It's just to re-evaluate the perfusion to the particular areas of the brain by which we perform these techniques of thrombolysis, and even the surgical thrombectomies can be performed. We have to establish the cause as well. It can be the atrial fibrillation that led to the dislodgement of the thromboembolic plaques. It can be the carotid diseases, almost 4% of the patients. Other causes, or even the idiopathic causes, are 64%. We can consider giving warfarin if it's the atrial fibrillation that gave rise to the thromboembolic plaque to be dislodged. It can be by the consideration of giving warfarin to the patient. If it's the carotid diseases, we have to consider the CEAs or stenting. The other causes, we have to treat the specific cause towards the development or the dislodgement of the thrombus in this particular patient. On the other hand, we have the 15% of the TIAs, which are known as the hemorrhages. The BP lowering is the most important and critical point over here that we have to perform. We even have to establish the cause over here. If it is the aneurysmal subarachnoid hemorrhage in 4% of the patients, it's the hypertensive hemorrhages in almost 7% of the patients, and the other varieties are almost comprising of that is 4% of the patients. For aneurysms and subarachnoid hemorrhages, we can perform the clipping of the aneurysm, or even a procedure which is known as the coiling of the aneurysm. These are the surgical procedures that can be performed for these patients. The hypertensive patients, we can perform the surgical methods. The other causes can be to treat the specific cause in this particular patient whom we are treating with and who is suffering from the stroke or the TIA. The deep vein thrombosis prophylaxis is something that has to be done in all of the patients. Then we have the physical exercises that are performed. We have the occupational and speech therapies that are performed for these patients. We have to evaluate for the rehabilitation discharge planning, as well as perform the secondary prevention, that is basically to avoid any further accidents in the near future. By giving off the patient or by prescribing certain medications to the particular patient. The treatment over here, as we all know, we have to start off with the ABCs and we have to treat the hypoglycemia or hyperglycemia. Either case is going to complicate the condition of stroke in this particular patient. The emergency non-contrast head CT scans are performed for this patient. Treatments are conducted. That is going to give rise to the medical support. IV thrombolysis is done for these patients. We have to perform the endovascular revascularization techniques. Antithrombotic treatment, that is giving the tissue plasminogen activator for these patients, is very critical over here, providing the neuroprotection. Now, how do we provide neuroprotection? It is by the drugs blocking the neuroexcitatory pathways and even to control the hyperthermia in these patients. Then even a lot of rehab centers are prescribed for these patients, and they also perform their particular roles while we are treating these patients. When we talk about the medical support that has to be given for these patients, we have to first of all optimize the cerebral perfusion by giving the subcutaneous heparin. Pneumatic compression stockings are also prescribed for these patients. The BP has to be maintained at more than 185, 110 millimeters of mercury by giving off the thrombolytic therapy for these patients. Lowering the HR, that is the heart rate, with a beta-1 blocker, adrenergic beta blocker, is again very important because these atrial fibrillations and flutters can further dislodge the plaques and further compromise the blood supply. Then we have to also prescribe the antipyretics, water restrictions, and IV mannitol is given just to control the cerebral edema that is building up in the patient. And we can also perform the hemicranectomies that are usually prescribed for these patients, and that can basically decrease the cerebral pressures and further cause which are basically further causing the damage to the brain. Now, giving off the intravenous thrombolysis or the tissue plasminogen activator, what are the indications? Who are the patients that are in which it is basically the first line of choice to give this tissue plasminogen activator? If it's a clinical diagnosis of stroke, the onset of symptoms to time of drug administration is less than 4.5 hours, and CT scans are showing no hemorrhage or edema of more than 1/3 of the middle cerebral artery territory. Age is more than 18 years, and the consent of the patient as well as the surrogacy has been maintained in a particular patient. So if you have a consent and if you have all of these conditions, we can safely give this tissue plasminogen activator just to have a better reperfusion of the areas that were compromised in a particular patient. The contraindications for giving this tissue plasminogen activator: if the BP is not sustained at 185 by 110 millimeters of mercury despite the treatment, then we have to look for whether it is safe to give this tissue plasminogen activator or not. Then if the platelet count is less than 100,000, hematocrit is less than 25%, or the glucose levels are less than 25 or more than 400 milligrams per deciliter. So it's basically a case of hypoglycemia or hyperglycemia. It's not safe to give the tissue plasminogen activator. The use of heparin within 48 hours and prolonged PTT or elevated INRs, because that is going to further basically complicate the situation by leading to the hemorrhages, rapidly improving symptoms. So it's no use to give this tissue plasminogen activator, or either there is a history of prior stroke or head injury within 3 months. A major surgery preceding 14 days, so that is again one of the risk factors over here. Gastrointestinal bleeding in the preceding 21 days, recent myocardial infarction. So all of these are basically the collective risk factors which basically contraindicate the use of tissue plasminogen activator in a particular patient. So we have to look for whether it is safe to administer this tissue plasminogen activator in a particular patient or not. Minor stroke symptoms, coma, and stupor are going to further complicate the situation in these individuals. Now, how do we administer it? The IV access with 2 peripheral IV lines is maintained. That is going to review the eligibility for the tissue plasminogen activator. Then we have to administer 0.9 milligrams per kilogram IV. It is given. The total dose by bolus and is followed by the remainder of the total dose over 1 hour. Frequent cuff blood pressure monitoring is done. No other antithrombotic treatment has to be given for 24 hours. For decline in the neurological status or the uncontrolled BP, you're going to stop the perfusion. So you have to maintain the BP at a normal level, and you have to perform a continuous monitoring while you're administering this tissue plasminogen activator in these individuals, or either you can even then go for a trial of cryoprecipitates in such individuals. Re-imaging of the brain after you have completed the treatment with the tissue plasminogen activator has certainly been done, and then we have to avoid the urethral catheterization for more than or equal to 2 hours. So even if you have to perform the procedure, it has to be a distance or a difference of 2 hours between giving off the tissue plasminogen activator and giving off the catheterization in the individuals. Now we can also perform the endovascular revascularization by these surgical techniques. We can perform the intracranial thrombolytics in a patient. Either we can also perform the stenting techniques by the endovascular mechanical thrombectomies. So all of these mechanical methods and surgical methods are basically the invasive varieties of the treatments that are usually employed these days for the treatment of ischemic stroke in the patients. The antithrombotic treatment with the aspirin is one of the variants that are basically prescribed to the patients when he goes home back to his normal life, and we are performing the rehabilitation for this particular patient. We can prescribe these individuals by giving them aspirin on a regular basis. Then obviously we can also give them certain drugs which provide them with neuroprotection. Now these drugs are basically blocking the neuroexcitatory pathways, and they also prevent the patient from hypothermia. So all of these drugs come into the group which provide the neuroprotection to these particular individuals. Rehabilitation centers and stroke centers have been developed just to perform the physical therapies for these individuals. If they are suffering from some sort of a disability after stroke, that is catered for. And obviously, they sometimes also require the speech therapies as well as the occupational therapies that are done for these individuals who are suffering or from stroke or any disabilities that basically led the quality of life to be integrated for these individuals. So in this particular lecture, we just focus on the variety of strokes. How can these basically the pathogenetic factors which leads to the formation of ischemic stroke as well as hemorrhagic stroke on the other hand, what are the complications and what are the management and treatment guidelines that we must be well versed with as a physician. So that is the end to this lecture. Thank you for watching sqadia.com.